Welcome to the World Parkinson's Coalition virtual YOPD program. My name is Shri Shripathy. I am your moderator for the next hour, and I am joined by our presenter, Rochelle Flanagan, and also John Ball. Rochelle is a registered dietitian. She was diagnosed with YOPD shortly after the birth of her second child. She's a World Parkinson Congress Ambassador alum. She's passionate about the importance of diet for Parkinson's disease and the unmet needs of women with PD. She's a co-founder of the Women's Parkinson's Project and co-founder of the digital health startup My Moves Matter. Hey, Rochelle.
Hi, Sheree. Great to be here.
Great to have you. We are also joined by John Ball. John was diagnosed with Parkinson's disease in 1983 at the age of 39, after 12 years of looking for a diagnosis. John turned 80 this year and is still active and engaged in life. He says, "I am living proof that a proper diet, good exercise regime, and a positive attitude and supporting wife and friends can create a life worth living." Welcome, John.
Thank you very much. Glad to be here.
Glad to have you. There are 9 talks in this virtual YOPD series. If you miss a session this week, do not worry, we are recording them, and they will be available next week for viewing. Our session today is on nutrition, eat well to live well. During the session, you will notice a box on the right side of the screen with 3 tabs. A question tab where you can submit questions at any time, a resource tab where you can download or open various resources mentioned in the sessions, and a poll tab where you may be invited to complete a poll in session. If you have your Zoom set to full screen, you won't see the tab, so just keep that in mind. Rochelle will be presenting, after which John will speak about his experience with Parkinson's disease. This will be followed by a question and answer session. Lastly, I want to thank our sponsor, Mitsubishi Tanabe Pharma America. We would not be here today without their generous support. Let's get started. Handing over to you, Rochelle.
Thanks, Sheree. Okay, I'm just going to share my slides here now. Get going. Okay, so great to be here with everybody today. Thanks for logging on. Sheree has done my introduction, so I'm just going to pick on. Just in terms of diet, this is sharing here we did a focus group with a number of people from the UK, Ireland, and abroad about what would they like to know more about diet, nutrition, and Parkinson's. Included people with young onset and early onset and late onset, and the topics that came up were, a personalized approach to diet for people with Parkinson's. People want to know about supplements, prebiotics, probiotics, advice beyond just the protein and medication interactions, what diet to eat for Parkinson's, and what about the different cultural perspectives, digestive and bowel issues, hormones in their interplay with Parkinson's and diet, and also just generally, people want to know what the evidence base is to help to use diet to help improve symptoms, and ultimately they want to have consistent advice from different dietitians. So I'm just going to my presentation is kind of going to speak to those topics that people asked about. So I suppose the first one is, what diet should you eat? There's no specific Parkinson's diet at this moment in time. However, what I've done here is I've split out the kind of typical diets that people ask about in relation to Parkinson's. And I've shown in terms of the benefits and the negatives of these diets. So from a Parkinson's point of view, the Western diet, you can see here with lots of red faces, is that it's not particularly good for Parkinson's in terms of it's, pro-inflammatory rather than anti-inflammatory. It doesn't help the microbiome. It doesn't help us as well in terms of symptom control. It doesn't help to potentially slow progression. It, again, is not great in terms of reducing the risk of dementia. It can lead to weight gain. And with the Western diet, there can be a lot of nutrient deficiencies. So we can have a lot of calories, but actually not get enough of the micronutrients, vitamins, and minerals that we need. In terms of the other diets, in terms of Mediterranean diet, it's the one that is showing the most benefit in terms of being anti-inflammatory, helping the microbiome, which is very important for Parkinson's. I'll explain later on. It's been shown to help symptom control, potentially might slow progression, also potentially reduce dementia. And in terms of weight loss, it can be beneficial if you're overweight or obese trying to lose weight. Then we come into the vegetarian and vegan diets. So the vegetarian diet can be very healthy, like the Mediterranean diet, which is kind of mainly plant-based. But there are issues in terms of the vegan diet where it can be much more strict. And so there can be issues in terms of micronutrient deficiency that one has to particularly be mindful of. Then in terms of people often ask about gluten-free, should I go gluten-free? And in terms of the gluten-free diet, they might have benefit in terms of anti-inflammatory, but not as much as the Mediterranean. It is not necessarily good for the microbiome because you're cutting out a lot of the whole grains, which are important for the microbiome. It can lead to weight gain because a lot of people eating gluten-free end up eating a lot more sugar because the foods aren't as palatable. And you can have vitamin deficiencies. I'm celiac myself, so I know this inside out. Then there's the low glycemic index diet, which is basically a healthy diet in terms of making sure that you're eating a lot of whole grains in the diet, but there's not much research to show necessarily a benefit for Parkinson's. Then you've got the ketogenic diet, which a lot of people ask about, but the evidence is very little in terms of keto at the moment. The trials are quite small, 8 to 10 people. There are definitely signals that the ketogenic diet can have benefits. In fact, there was a study just published today. Now it was more of a preclinical animal study that showed that the constituent that is produced out of the ketogenic diet might actually help to break down the misfolded proteins that are in the brain when we have Parkinson's. But again, preclinical is a far long way from taking the ketogenic diet. And the biggest thing about what diet you follow is one that you can actually adhere to on a regular basis. And the ketogenic can be quite difficult to stick to long term. Then there's the fasting diet. A lot of people ask about that, and there's some information or research showing that potentially it might be beneficial, but the negatives can be very large in terms of weight loss, which actually is possibly a bigger predictor of poor outcome than following a fasting diet. So you have to look at the pros and cons and see what is the best diet to follow. So from the research, really the diet that is showing the most benefit is the Mediterranean style diet. And this is basically where you're focusing on a more plant-based diet. So you're having plenty of fruit and vegetables in the diet. You're eating nuts and seeds. You're having moderate amount of dairy in it. You're having white meat. You're reducing your red meat. You're having legumes in terms of pulses, chickpeas, kidney beans, lentils, etc. And you're keeping your sort of top shelf foods in terms of sweets and cakes and biscuits to a minimum. But another important part of the Mediterranean style diet is actually community in terms of eating together, not eating alone, and also incorporating that with exercise as well. There is a diet also called the MIND diet, which was originally sort of developed in terms of Alzheimer's, and it's very similar, but there are kind of a couple of key points. One is they really focus on eating the dark green leafy vegetables a day, but basically any green leafy vegetables. So it could be broccoli, it could be kale, it could be coming up to the Christmas now, Brussels sprouts. And then also in terms of berries, making sure in terms of fruit, eating berries at least twice a week has been shown to be beneficial in terms of brain health, but also in terms of Parkinson's. The other area in terms of MIND diet that they focus on is the beans, in particular the legumes, getting in the pulses, etc. But overall, in terms of Mediterranean diet, a core feature is also the fats. So things like olive oil, avocados, nuts, they contain a monounsaturated fat, which is shown to be beneficial. And also oils coming from fish. So your oily fish like salmon, mackerel, etc. And the most important thing with regard to these diets, it's also the phytochemicals that are in the Mediterranean style diets, which are more plant-based. It's the colors that give you all these phytonutrients. So if your plate is very white, it means that you're not getting a lot of these phytonutrients in. So you can see the colors popping off the plate, and this is because all these lycopene, beta-carotene, lutein, these are all really good for us living with Parkinson's. So just in terms of some of the research, it's showing that the MIND and Mediterranean diets have attracted attention because in terms of them being able to potentially slow the progression of Parkinson's and preserving cognitive health and protecting against depression. And we know that depression is a non-motor symptom of Parkinson's. Also, it's shown that people who adhere to a Mediterranean style diet if they did get Parkinson's, it was later onset than earlier onset. And also in terms of the symptoms, the Mediterranean and Medi diet scores are associated with fewer patent symptoms over time. So there's lots of good signals that the Mediterranean style diet is the one for people to follow for Parkinson's. In terms of most recent sort of randomized controlled trials, which is kind of the strongest form of evidence for a diet, is showing that people who adhere to the Mediterranean diet and Parkinson's for over 10 weeks, remarkably, is what they said, increased executive function, language, attention, concentration, memory, and the total cognitive score. And in terms of another randomized controlled trial from the same sort of cohort, showed in 70 patients, showed that there was a significantly increased total antioxidant capacity. So that's this anti-inflammatory sort of benefit. And also in terms of the UPDRS, which is the marker for how well we're doing, actually was improved. And also in terms of a study that was done by a dietetic colleague that ran over 5 weeks, the Mediterranean Diet Intervention Study, there was only very small 8 people, that showed that it improved constipation, changed the microbiome. But the caveat was there, as I mentioned, the Mediterranean diet, you can lose weight on it. So for those who are underweight, this is something that we have to be mindful of. But in terms of from a young onset Parkinson's, well, to be honest, all people with Parkinson's, but when you're young onset and you're working, executive function is really important. So that's where, your ability to multitask, your ability to concentrate on, several things at the same time, the brain fog, not having that, being able to concentrate and pay attention. So these are really important for young onset people with young onset Parkinson's. So also in terms of some of the research done, so in the trial I mentioned there at the end that Carly Rush, a dietetic colleague, did, they did a Mediterranean diet score, and the average was 4.4 out of the participants. I actually did a survey of people with Parkinson's worldwide, and we did a kind of Mediterranean diet score in that, and people scored 6 out of 14. To give you an idea of how that compares to what is good, a score over 10 is good or very good. So really people are falling into weak adherence to the Mediterranean style diet to moderate to fair. So there's a lot of room for improvement, and there's a lot of room to actually benefit from diet for your Parkinson's. This is another key aspect in terms of Mediterranean diet, is really limiting the ultra processed foods. We know with research going back over years, that basically diets that are more traditional are associated with a lower risk of diagnosis of depression, anxiety, and insomnia, and diabetes. And those diets that are more Western processed tend to be associated with a higher rate of depressive disorders, anxiety, insomnia, and diabetes. And from a Parkinson's point of view as well, the top shelf or ultra processed foods tend to have a lot of sugar in them. And sugar is not the best friend of people with Parkinson's. It doesn't mean you have to cut out sugar completely, but if we're having a lot of it, it can cause problems. So this can result in terms of people having too much sugar from impulse control, in terms of some medications people with Parkinson's might be on, like agonists. It also can happen in terms of things like REM sleep behavior. If your sleep is, affected, you're tired, you can crave more sugar. Depression, cognitive impairment, chronic pain, fluctuations in your symptoms, as I mentioned, poor sleep, fatigue, and the microbiome can affect your tendency to want more sugar, and also hormonal fluctuations during the menstrual cycle, and also perimenopause can also trigger eating more sugar, and this ultimately can be a negative impact on our Parkinson's. This is in terms of the Mediterranean diet, a number of friends, I think Omatola Thomas is on tomorrow, who set up Parkinson's Africa. And I remember saying to me, well, what, the Mediterranean diet doesn't mean anything to me. She's Nigerian living in the UK. It doesn't speak to me. So it's very important to understand the Mediterranean diet is a pattern of eating, the way you eat your foods. And you can also follow that Mediterranean pattern through, say, an African version or an Asian version. So it's using the same indigenous foods that you would eat that are seen to be very healthy. So for example, in Nigeria, the indigenous Nigerian diet is actually extremely healthy. What's not healthy is the fact that the Western diet has got in and changed that. So really it's about looking at your cultural diet and sticking to the healthy foods within your diet, but using this sort of Mediterranean pattern as a way to guide you. So there's a few considerations that people often ask about with regard to Parkinson's and the diet, and that is dairy is a big one. And there has been research to show that every 200-gram increase in total dairy intake was associated with an 11% increase of the risk of developing Parkinson's. But on the flip side, it actually is associated with a 12% decrease in cognitive impairment. So on the one hand, it's increasing potentially the risk of Parkinson's, but the other hand, it's actually improving, it's reducing your risk of having cognitive issues. So in terms of the reasoning between the link of dairy with the increase of risk of Parkinson's, of getting it, there's some kind of thoughts. Might be pesticides, might be thing called uric acid, might be due to bacteria, the microbiome, or a particular sugar content in the dairy. The jury is still out. A paper literally came out yesterday that sort of said that really in the main, they felt that there wasn't an association between dairy and Parkinson's risk. But interestingly enough, in the research, it showed that if there was an association, it tended to be more in men than it was in women. And we don't know the answers to this yet. But there's a lot of variability in the dairy research. There's no research in terms of dairy, in terms of progression of Parkinson's when you have it. Also, all of the research is association, it's not causation. And also we can't ignore the benefit of dairy that is showing in terms of benefit to cognition. And cognition is something that we all have, on our mind in terms of keeping our brains healthy and keeping our cognitive function, strong. So what I would say as well in terms of the Mediterranean diet, which is showing the most evidence at the moment for the benefit for people with Parkinson's, is that it includes a moderate amount of dairy. So that is around 2 servings of dairy foods a day that you can, keep in your diet. So the other topic that comes up in terms of, on a regular basis is around bowels, and bowel health. And one thing with Parkinson's, about 60% of people with Parkinson's, including young onset, suffer from constipation. And the thing about constipation, I'll just explain here in terms of sorry, my slides have slipped on forward there. But when you take the tablet, most people are going to be taking a levodopa tablet at some stage, which is replacing your dopamine that we have lost. When you take that tablet, it has to go down your throat, into your esophagus, rather, around your esophagus, into your stomach. Then it has to travel to your small intestine. Then it has to be absorbed into your bloodstream. And then it has to travel all the way to your brain to replace your dopamine. So one of the issues in terms of being constipated is that it can have an impact on that levodopa getting absorbed and getting to your brain. But the other thing that can happen is that when you're constipated, it can actually lead to a buildup of less healthy bacteria in your bowel. That less healthy bacteria in your bowel, believe it or not, can actually eat your levodopa. So it means that you don't have as much to get to your brain. So that's why it's very important to get on top of your bowel motions. And also for those who don't suffer from constipation, it's just regardless, it's really important to keep your gut health and your microbiome on the healthy side. And that's where the Mediterranean diet is very positive, because again, it's all the constituents of the fruit and the vegetables, the whole grain carbohydrates, that they feed and nourish the microbiome. So in terms of feeding the microbiome and keeping the bowel movements healthy, it's about, getting enough fiber in the day. So you need about 25 to 30 grams of fiber in the day. A lot of people with Parkinson's don't get that. A lot of people without Parkinson's don't eat that amount of fiber. But so that's something, and you can actually look at the nutrition label on your packaged foods, and you can see how much fiber is in the foods that you eat. So for example, in terms of breads, you can look at, and in terms of fiber, it's very important that you get a mixture of fiber, so soluble and insoluble fiber. So what is that? So soluble fiber is basically you get it from your fruits and vegetables. So getting in at least 5 to 7 servings of fruit and vegetables combined across the day. The average in terms of most people is 2 or 3 a day. So if there's one thing you can do after this talk, it's starting to increase your fruit and vegetable intake. Because again, you can see all that color giving you all those phytonutrients. The other form of soluble fiber comes in things like your pulses, your chickpeas, kidney beans, lentils, etc., and things like your oats. So what they do is this soluble fiber gives a gel consistency to the stools. That helps you to move it more easily out through the bowel. And then you've got your insoluble fiber. That's nature's roughage, natural room, to sweep out the gut. And that's making sure that you've got whole grains. And you'll see the difference between these two pictures here. So if your diet, again, is very white, you're likely to have very little fiber in it and not enough insoluble fiber. So you want things like whole grain breads, whole grain rice, whole grain pastas. And there's a whole range of different fibers, grains that you can choose from quinoa to millet to rye, sorghum. There's a whole range to make your diet more interesting. So a lot of people then ask in terms of constipation or, about probiotics. And if increasing fiber, and what's the other thing to mention is in terms of fluid. So there's no point in increasing loads of fluid in your diet, fiber in your diet, if you don't make sure you get enough fluid in, because you could potentially make your constipation worse. So you want to make sure you're getting enough fluid in. So generally speaking, that's about 1.5 to 2 liters of fluid a day alongside your fiber. And also exercise is important for moving the bowel. But if you're finding these combined things are not helping your constipation, then a probiotic may be beneficial for helping to move the bowel. Now, the research, there's only a couple of randomized controlled trials, but there are particular probiotics. There's one in the UK called Simprove, where it has shown that it has benefited people in terms of helping them to move their bowel. Now, I found that some people find it's worked and other people hasn't worked. It's an individual thing, but what I'd say is, to trial it for a maximum of 3 months. If it's not moving the bowels, then, maybe not to continue it on, because it can be expensive. The other thing is to let your neurologist, your Parkinson's nurse, know if you're going to be trying anything different. Just a note on prebiotics and probiotics, I think this is important to share in terms of 2 randomized controlled trials that show that potentially say the benefit for constipation. But in terms of helping to improve motor and non-motor symptoms of Parkinson's, the evidence is not there yet. I think that it's definitely coming, but the guidelines are at the moment not to be taking, probiotic supplements off the shelf, but actually to speak with your consultant about maybe if it is constipation as a problem, a specific one to help with that. On the note of the microbiome, I just want to mention again that there's 2 things with regard to the bowel that people can suffer from with young onset or anyone with Parkinson's. It's Helicobacter pylori, which is a infection in the stomach, which has actually been associated with the risk of developing Parkinson's. And then there's also a thing called SIBO, which is small intestinal bowel overgrowth. And that can basically be a proliferation of this unhealthy bacteria that I was mentioning. And the issue with these 2 sort of bacteria in the stomach and in the bowel is that they can interfere with your levodopa, that's your dopamine tablets, being absorbed. So again, they basically eat the levodopa. The other thing is they can impact in terms of vitamin B12 absorption, iron absorption, and vitamin D absorption as well. So generally speaking, again, eating a diet that's rich in plant-based foods is associated with healthier gut bacteria and has also been associated with reducing the risk of H. pylori. In terms of other things with regard to the bowel, laxatives. People are often very fearful of taking laxatives, but I always say that with Parkinson's, the bowel is lazy to a certain extent anyway, because it affects the lack of dopamine affects the movement of the bowel. So not to be afraid of taking laxatives if the traditional lifestyle route does not work. And there are different types of laxatives, and people can respond differently to different ones. So speak to your neurologist or partner. Do not suffer with constipation. Like dietitians, we like talking about bowel movements because it's a big part of people's lives and affects their health. And in Parkinson's, it's a huge impact on how well you're going to feel with your Parkinson's. There is an exception with regard to fiber intake, and that is if people suffer from a thing called gastroparesis. And I know a lot of people with young onset who are presenting with these symptoms. So heartburn, nausea, vomiting, feeling full quickly when eating, belching, loss of appetite, weight loss, and for some people, change of blood sugar if they have diabetes. So this is basically gastroparesis symptoms, and it's where basically the food is slow to move out of your stomach. And if the food is slow to move out of your stomach, it's going to make you feel unwell because it's not emptying. But also in terms of your levodopa tablet, it's going to get stuck there and it's going to get broken down, and you're not going to your symptoms are not going to go away. The tablet won't turn on as such. So there is a guideline with regard to what kind of dietary intake to take for people who have these symptoms, and it's actually to avoid high fiber. So if you're suffering from these symptoms, you need to speak to your doctor and your neurologist about it. In terms of bone health, osteoporosis and osteopenia are very high levels in people with Parkinson's. Women tend to have a higher level, but that's the same whether you without Parkinson's. So basically, 3 out of 4 women over the age of 50, for example, in Ireland, have a higher risk of osteoporosis without Parkinson's. Put Parkinson's into the mix, it's an even worse situation. So vitamin D deficiency is correlated with the increased risk of fractures. And also in terms of osteoporosis, I'm going to explain about homocysteine. It can be affect your bone health as well. But it's shown that women in particular, maintaining bone health could potentially play a role in slowing disease progression. And it's really important that you all get assessed in terms of your bone health. So there's a thing called a DEXA scan, which actually can get done to see what the strength of your bones are and whether you have osteoporosis or osteopenia. And there has been a research study done where it's showing a combined supplement of vitamin B12, folic acid, and vitamin D3 remarkably decreased homocysteine, which is a negative metabolite for Parkinson's. But this supplement helped to increase the quality of life in people with Parkinson's. So the message here is get your bone checked. And then in terms of supplements around bone health, is making sure you're getting enough calcium in the diet and you're getting enough vitamin D in the diet. So in terms of your calcium, you're talking about between 700 and 1,000 milligrams of calcium a day. And in terms of your vitamin D, generally about 10 micrograms a day, or it depends in terms of US, it's 600 IUs under the age of 70, and it's 800 IUs over the age of 70. So these can depend on your age. And in terms of your vitamin D, you can get it from some foods, but generally speaking, often not enough. And when you're coming into the winter months, where those people are in countries that are in the winter, you need to supplement with vitamin D. Generally speaking, with people with Parkinson's, I would say year-round supplementation with vitamin D is very important. And then to look at so if you're cutting out dairy, for example, you're cutting out a lot of your calcium for your bone health. And the reason why bone health is also very important is because when people with Parkinson's, they tend to trip, and that happens with young as well as older people with Parkinson's. And if you break a bone, it is not a good place to end up in hospital. And also if you're in a cast or something, often that can mean that you can't exercise, and so your symptoms can get a bit worse over the time of being in a cast, for example. The other thing then I'm focused on is vitamin B12 and homocysteine. So we know that basically long-term use of vitamin levodopa, the tablets, can lower your vitamin B12 and can lead to symptoms called neuropathy, so it's pins and needles. So the left-hand side here, you'll see here are all the symptoms with regard to vitamin B12 deficiency. So balance problems, muscle cramping, twitching, tingling. They all are very similar to Parkinson's symptoms. So often people think that they're progressing, but potentially it is that they're vitamin B12 deficient. So it's very important that you know, and it can be difficult because you're thinking, is it just my Parkinson's? But it's a good idea to speak with your neurologist, with your doctor about getting your vitamin B12 levels checked. The other supplement I just focused on was the mucuna pruriens, because that's something that, particularly in the States, a lot of people are considering, taking, because it's a natural form of the levodopa. And I've just put up here a quote from Professor Michael Oken, who's a worldwide recognized movement disorder specialist, saying that, for some people, and particularly in young onset, I've seen this, is what they call brittle Parkinson's disease. So it means that even the smallest doses can actually precipitate dyskinesia, which is sort of a side effect of levodopa, where if you take too much, it can kind of make you sort of move more than usual. So there's potential that this supplement might help there, but unfortunately, there's not a lot of protection around the different mucuna supplements that are out there. So we don't know whether they're safe or not. So again, if you're considering to take one of these supplements, you need to speak to your neurologist about it. In terms of diet affecting your medication, so back to the stomach. So if you have a large meal high in fat and protein, it slows down the movement again of the stomach emptying, and so your tablet basically gets stuck in your stomach and doesn't get to where it needs to be, which is your brain. The other thing then is in terms of protein foods, so chicken, fish, eggs, milk, all of those protein-containing foods can interfere with levodopa absorption across your bowel, but also most importantly, when it tries to cross your brain, basically the amino acids, the constituents of your protein foods break down to amino acids, and they try and cross the brain at the same point as your levodopa. And so they basically compete. And it means that if you take your levodopa with a meal, you might notice that the levodopa doesn't work as well and your symptoms aren't as well controlled. So we generally advise you to take the levodopa 30 minutes to 60 minutes before, or 60 to 100 minutes after, 120 minutes after meals. The reason it's longer after meals is because it takes longer for the meal, especially if it's a big carby meal, to empty out of the stomach. So in terms of, on that point, these are classic Irish meals. And I know in the States, the portions tend to be even bigger. If you're having like large lumps of meat, it is definitely going to interfere with the uptake of your levodopa. So it's all about this sort of, for people with Parkinson's, when you're newly diagnosed, you might notice a change in your symptoms, but often people over a bit of time will notice that their medication, when they take it, doesn't last as long, and they notice their tremor coming back, or, you know, their, maybe in terms of their concentration gets a bit worse, or whatever their symptoms are. And this is what we call wearing off, in terms of when you take your tablet, it gets to your brain, you feel really good. When it starts to wear off, so it's a bit like diabetes medicine with your insulin going up and down. It's the same with your dopamine, can fluctuate. And so when people are taking levodopa 4 to 5 times a day, it can be difficult to time your meds and your meals. So people start to sort of leave their protein out, and that can lead to weight loss, and that's not good in terms of your Parkinson's. So in terms of guidance around this, is to try and keep your protein to a max of 1 gram per kilogram of your body weight. Spread your protein out across your 3 meals. But if you're finding that there's a particular time of your day where you're kind of more off in terms of your symptoms, well, maybe that's when you actually have less protein. But also, if you're sort of, you know, in the evening time, you're not going to be out and about doing as much, it might be that you have more protein then, because you don't mind being a bit more off than usual. For people who are noticing these on-off, which can happen a lot in people with young onset, is to follow a thing called the protein redistribution diet. This is basically where you move all your protein to a time of the day, as I mentioned, where it's not going to bother you as much being off. So in other words, if you're working during the day and you want to be as on as possible, but your symptoms are well controlled, then you would actually eat most of your protein in the evening time when you're not working. And actually the research on this it's pretty thin on the ground, but it's fairly compelling, and we need more research on it. But this particular study showed that within patients who were treated with levodopa, progression was inversely correlated with adherence. In other words, people who stuck to the protein redistribution diet tended to have a slower disease progression. And I said, that's my point, in terms of there are things that diet can do before you get accelerated up on your medication. So in this study, it actually showed that basically the disability score decreased from 34 to 23 just after 30 days following the diet. And then this one here, it showed that their disability score dropped from 31 to 18.7. Their percentage on times of 76% more on times during the protein redistribution diet. And also in terms of their speed, their walking speed increased from, 16 seconds, improved in terms of, they were able to make the distance quicker. So in terms of just putting this into context, if you were to follow a protein redistribution diet, if you're a 55 kg woman, your total protein for the day would be 55 grams. You would take 10 grams of that during the day, and then the rest of the protein at night. I'm just showing you here how much protein is in a particular portion of, a chicken fillet. So it just getting home the point that we can all be eating way too much protein, which can be impacting perhaps the levodopa absorption. This is just a sort of a handy ready reckoner to show the different food portions and what size would contain 10 grams of protein. So in terms of the other thing I mentioned is not to cut protein out of your diet if you're sort of finding that your tablets aren't working, because protein helps to combat fatigue, which many of us suffer from. It's very important for your immune function, helps to maintain your muscle mass, which is really important for Parkinson's, and also helps to make dopamine. So It's about moderating your protein, not having way too much, and noticing if it interferes with your medication and adjusting accordingly. So one of the things to watch out for with the protein redistribution diet is that some people, it can make their dyskinesia worse. And this is if you can understand. So basically when people have dyskinesia, it's because they're absorbing more of the levodopa, and that spills over in the brain and causes excess movement. And if you move your protein, all to the end of the day, it means you're going to absorb more of your levodopa, which if you're someone who's suffering dyskinesia, is going to make your dyskinesia worse. So a way to counteract that is to actually, reduce your levodopa dosage. So that helps to improve the dyskinesia side effect. It's also shown that in terms of taking carbohydrate, a higher proportion of carbohydrate to protein intake, again, about moderating the amount of protein in the diet. And also in terms of weight loss can occur with the protein redistribution diet, but you can counteract that with high calorie supplements that are more fat carbohydrate based. But there is some research beginning to show that some protein supplementation actually doesn't interfere. So for example, there was a study to show that an exercise rehab program that had protein redistribution diet in it with a 10 grams of whey protein supplement twice a day, it didn't interfere with the levodopa absorption. So I know a lot of people with young onset, often you would use, protein energy drinks, for example. And also in terms of rehab treatment, it's shown that basically combining physical therapy, rehab, and nutrition is more powerful than either alone. And this particular study showed, again, a 20-gram whey protein formulated twice a day with leucine and vitamin D actually helped to improve the lower extremity. So basically you can walk better and preserve muscle mass, which is really important for people with Parkinson's to avoid falls, for example. And just to highlight more recent information that I came across with regard to amino acids in terms of levodopa absorption. So not every amino acid is the same. So there's some research to show that different foods break down to different amino acids, and some of them actually help levodopa to be absorbed. Some of them compete and some of them don't. So we need more information, and potentially there's a supplement that could be developed that has specific combination of amino acids that would actually help levodopa absorption. And this is a very busy slide, and those of you who are interested in it, you can look at the reference, but this again was a nutrition researcher which actually looked at the different amino acids and actually could, suggesting which ones are more positive for people in terms of helping Parkinson's and ones that compete with your levodopa. So I think there's a lot more here for us to benefit from. Just kind of coming towards the end in terms of weight gain is a big issue in Parkinson's, particularly around your agonist medication, which can cause impulse control. So this hyperdopaminergic eating, so compulsive eating, nocturnal eating. Also can happen with DVS, very common in DVS that people gain weight. And also there's a thing called hypodopamine. So when you've low dopamine, that can also make you overeat. So that's in terms of the fatigue, apathy, because basically your medications, you don't have enough dopamine. In terms of cravings, it's something that people talk about all the time, particularly young onset, in terms of craving this sugar. And that can happen from that low dopamine. So if you're not aware in terms of when your medications are coming on or off, so if you're going off, your dopamine is running out, it's a bit like when people are on insulin and they have a craving for sugar. It's the same with dopamine. Your neurons are crying out for more dopamine. So basically, when you're going low, it can mean that you kind of get this craving. So just watch out for that and make sure that your timing of your meds are correct and to be aware of it and to have a healthier snack ready for that craving. In terms of, say, weight gain, it can be up to 6 kilograms at 12 months with people post-TVS. So you really need to ask for referral to a dietitian. Weight loss is a big issue. In terms of a survey that I did, 30% of people reported they lost weight unintentionally since diagnosis. And this is associated with a more rapid decline in Parkinson's. So we want to get on top of weight loss. And there is some research showing that basically some of the appetite hormones are affected. So our appetite tends to, and a lot of people will mention that, young onset or otherwise, in terms of their appetite. And with regard to, again, young onset, obviously doing a lot of exercise, is to be aware in terms of when you're exercising that you're on, that you have your dopamine is taken at the right time, but also in terms of your meals, that you're not, trying to exercise when you've taken food with your medication, and it's going to impact how well you can do in your exercise. In terms of the importance of diet with people with Parkinson's, again, it did a survey and it showed that 82% rated diet as important in Parkinson's, but actually we looked at a self-knowledge rating. It showed that 35% said that their knowledge was average and 25% was poor or very poor. So we have a lot of room to improve knowledge around Parkinson's. And in terms of what people's experience of getting advice on diet and nutrition from their health services, people have reported a complete lack of information, lack of understanding of diet and Parkinson's by neurologists, complete lack of resources, a lack of dietitians who understand the Parkinson's specific needs, and a lack of referral to dietitians. And this is the reality. I'm just going to actually ask for a poll to be put up, which is asking you to actually to answer the poll in terms of have you ever seen a dietitian? So if you could just, those of you can see the poll in your platform there, is maybe just to answer that question. But just in terms of, you can personalize your diet with the guidance of a dietitian, because these are all the things that dietitian can help you with in terms of your protein redistributed probiotics, everything that I've explained. But the reality is that 84%, in terms of recent studies, 84% of people with Parkinson's were never referred to a dietitian, and 87% of people with Parkinson's never asked to be referred to a dietitian. So if you don't ask, you won't get. And I actually asked a student here in Cork, in the University of Cork, she's doing her master's, to do her master's project on the knowledge of dietitians in terms of Parkinson's in Ireland. And it basically corroborated what we know, which was that they're not getting training with regard to Parkinson's. They're not being included in the multidisciplinary care team. So that's why, referrals aren't happening. And they really felt there's a huge need for training of dietitians and other health professionals with regard to diet. So how can you get access to a dietitian? Request it to your neurology team, through your GP or PCP, to your community health centre, through private dietitians. But what I would love to see is it's something that's part of the multidisciplinary team. What I'd say is the future is bright in terms of the benefit of nutrition for young onset people with Parkinson's, because there is a role for personalized care, and that is not there at the moment. And I think people are going to hugely benefit by getting access. So these are all the different things that we're working on at the moment, but ultimately in terms of the future, as I say, it is definitely bright. And there are a number of nutrition and dietetic resources that I think have been listed in the panel that you're looking at. So I'm going to finish there, just got to the 40 minutes. I'm going to hand over to John, who's going to share an amazing story in terms of his journey with Parkinson's, and also how diet has played a role in that. So over to you, John.
Thank you very much. I'm glad to be here, and I have a little story to tell. Thanksgiving 2024. What does a person need to know about young onset Parkinson's? What does he need to know about nutrition? Everything. Let's face it. What you don't know can kill you. When it comes to nutrition, I think Thanksgiving is the best holiday in America. Am I getting through? Okay. Last Thursday, we celebrated Thanksgiving at my house in Southern California. It's always been my wife's favorite holiday, her time to shine. We had 29 people in the house throughout the day. Not all at one time, but all of them were there to enjoy a meal with our family and our friends. We indulged ourselves in roasted turkey and baked ham, mashed potatoes and candied yams, stovetop stuffing and cranberry jam. Along with the meat and potatoes, there was corn salad and pasta, almond green beans and baked carrots, boats of gravy and a nougat kugel. And then there were the desserts, sugar cookies and pies of pumpkin and cherry, as well as lemon meringue and lime cheesecake. There were candy snacks and chocolate oranges and a wide variety of drinks served along the way. It was glorious. I know we can't eat like that all the time, but once a year, I think it's okay. It makes getting to 80 years old worth the trip. The most surprising thing was that we were all still there to give thanks and to enjoy each other's company. When I was diagnosed with Parkinson's disease back in 1983, at the age of 39, that did not seem very likely. My symptoms started when I was 27, and I struggled for 12 years just to get a proper diagnosis, because young onset at the time was not even a term in use. So how did I manage to live well with Parkinson's for over 50 years? I focused on the basics: study hard, work harder, take care of the people around me. Those are fundamental to success, regardless of what challenges come your way. We all face challenges. It's what we do about them that makes the difference. So what did I do that was different than anybody else? First, I had to separate the things I couldn't control, like death and taxes, from the things I could control, like my attitude, my level of fitness, and my diet. After diagnosis, I focused on what I could do rather than lament the things I could do no longer. I discovered I could run again, so I ran regularly. In fact, for more than 30 years, I ran 3 or 4 times a week and finished 25 marathons and even more half marathons. Running gave me a chance to create Team Parkinson, and together we raised more than $3 million for PD research. I discovered I could still work hard on the job, and it paid off with a promotion to manager a year after revealing my Parkinson's diagnosis. I was able to work for 19 years at full time after my diagnosis. And I must say the company I worked, Honda, was very generous in making sure that I could continue to work throughout that. I also discovered that I could still learn something new every day. So I decided to learn as much as I could about PD. With that new knowledge, I was invited to speak frequently at PD support groups and at national and international conferences. My personal experience at PD led me to write a memoir titled Living Well, Running Hard. The book has been helpful to many people, encouraging others to face their own challenges. I applaud those like Rhonda Folds and Bill Bucklew, who have taken the idea and run with it further than I ever could. With Edna's help, I also managed to take control of my diet. I fix my own breakfast daily, usually cereal, toast, and juice, and sometimes I fix my own lunch on a bowl of chili or soup or rice and chicken bowls, etc. Dinners I leave to my wife, Edna. Doing this, I have maintained my weight and fitness over the long haul. I still have a cookie habit and a distaste for okra, but I try to be open to new ideas, to stay sharp so that I can be useful to others. In my 50 years of living with Parkinson's, the biggest gain in the PD community came when the focus of treatment shifted from symptomatic relief to improving the patient's quality of life. Quality of life with PD is driven by several factors, some controlled by the hospital, doctor, or clinic, but most of them are in the patient's and/or care partner's hands. I urge you to take control because your life is in the balance. And balance, for me, a balanced diet is a cookie in each hand. Thank you.
Thank you so much, John and Rochelle. And John, I'm not sure we can be friends if you don't like okra. I'm gonna have to rethink our connection. All right, we have a lot of questions that have come in, and I have a lot of questions of my own, but I want to get to the questions from the attendees first. So Rochelle, some of these are going to be directed to you, and I have a couple for John as well. I hope we can get to them all. One of the first questions is drinking wine really necessary for the MIND or MIND diet? And can you talk about how people can activate that benefit when they might be allergic to alcohol?
So, in terms of the Mediterranean diet, yes, wine is kind of part of that, but it doesn't mean that people have to drink wine to get the benefit from the Mediterranean diet. And in terms of the quantity, like it's 100 mils, it's very small. And certainly in Ireland, no one ever pours himself 100 mils of wine. So you obviously need to be aware in terms of the interaction of alcohol with your meds. So the benefit is kind of from the grapes itself. Again, it's the nutrition inside the grapes. So you can use grape juice. It's not as good as the wine in terms of the research of the kind of constituents, but it certainly goes a good way to be beneficial. But I wouldn't be hooked on the alcohol as being a necessary part of the Mediterranean diet. I'd be focusing on all the rest of the elements. And then what was the other part of the question? Was there?
I think how do people get the benefit of that who are allergic to alcohol? But I
Yeah,
think you just
yeah.
addressed that.
Yeah.
Awesome. Second question, is coconut milk or almond milk considered dairy?
No. So neither. So they would be non-dairy sources of calcium, but only if they're fortified. So when you buy these non-dairy milks, you need to check the labels to make sure they're fortified with calcium, because the whole point is to get calcium, if you're not getting your dairy, which is a higher source of calcium. And just be mindful, almond milk, although it is a good source of calcium, in almond milks, it tends to be quite low, so it needs to have the fortification as well.
Awesome. I'm going to ask John a quick question. John, you mentioned that you eat cereal for breakfast daily, I think. What do you use as a liquid in your cereal? Do you use dairy milk, almond milk, oat
Actually,
milk?
I do. I first load the bowl with about half full of blueberries or strawberries. Then I pour on the cereal, and then I pour on milk. I usually use lactose-free 2% dairy milk.
All right. I had a friend who used orange juice when she ate her cereal. So that was very interesting. All right.
Yeah, but I usually take a glass of juice along with, could be orange juice, apple juice, sometimes grape juice to go with the breakfast.
Awesome. So on the topic of juice, just a quick question from me, and I know other people have asked this. Rochelle, when it comes to juice and getting your berries, a lot of people eat smoothies or drink
Mhm.
smoothies. How does that work in terms of fiber since all of the fruits are being blended together?
Yeah, so from a roughage point of view, when you blend it, you're not getting the benefit. So when you eat an apple, you're having to eat the skin actually, has the roughage in it, or a pear. So when you blend it down, you're not getting, you're blending down that fiber. That's one thing. In terms of also in terms of smoothies, when you blend them, you basically immediately start to release the nutrients. So that can over time sort of, if it's in a bottle, reduce the nutrient content. And also in terms of the glycemic load, so basically that's the load of fruit sugar, is a lot more in a drink of fruit than it is when you eat 3 pieces of whole fruit. So because of the roughage of the fruit, it helps to slow down the digestion of the sugar, and so your blood sugar spikes are less. And also there's more fiber in eating the 3 pieces of fruit. So I always encourage people to eat the fruit more than juice the fruit.
Can you add fiber to your smoothie? Does that help in terms of roughage?
Yeah, you could. So you can add in, it'd be quite common. People might have an oat fruit smoothie in the morning. So that is, another option of getting your fiber in. So, and some people don't like fruit, so sometimes then the smoothie is an option. It's all about weighing up the pros and cons and what people are going to eat. There's no point in telling them to eat fruit if they hate fruit. But if you can hide it in the smoothie and they like it, well, that's another way of, so it's about being practical.
It sounds like you need to be an air traffic controller to manage your body and Parkinson's and nutrition.
Well, I think at the end of the day, I think that's the thing. It sounds quite complex, but if we look at the Mediterranean diet, it actually is quite straightforward in terms of approaching the diet from healthy eating perspective. So what I would say is to people to download the Mediterranean food pyramid and basically look at the different, it kind of gives you quantities and actually, do a little food diary for yourself and see how do you compare over like a 3-day period. Are you getting in your fruits? Are you getting in your berries? Are you having oily fish once a week? So that's a way for you to sort of compare and not, make it too complex.
All right, here's another question from the audience. When a food label lists bleach, what does that mean? What is that ingredient?
Leach.
Yes, bleach.
Okay, well, I would think I would just put it back on the shelf and look for something that doesn't have bleach in it. Would be I've never heard of a food having bleach, but that's pretty concerning. I would just put it back.
All right, next one. Nitrite in meat and how it relates to Parkinson's disease.
Yeah, so in terms of nitrites, they are very much associated with cancer risk of the bowel. So generally speaking, it's shown that there's no amount of processed meat that's not associated with bowel cancer. And it's about the nitrate is one of the concerning constituents in processed meats in terms of cancer. In terms of Parkinson's, I'm not aware of studies that are showing a sort of link, but I think anything that is going to be, bad for sort of cancer potentially is bad for health generally. So trying to keep those processed meats to a minimum. And you can often have, meats that aren't preserved in nitrates.
Got it. So fruits and vegetables are very important for our nutrition, but a lot of them have pesticides. And also there's the option to go organic as well, but that's very expensive. And as you know, we have to spend a lot of money on Parkinson's disease therapies. What are your recommendations on how to get healthy fruit and vegetables that are maybe not so expensive or in
Yeah.
general?
So I think, at the end of the day, in terms of the evidence with pesticides, is strongest with regard to occupational exposure. So if you work with pesticides, you've a much stronger risk. What I would say in terms of foods, there's a thing called glyphosate, which is a pesticide that can get into food. So it's about how you prepare your foods. So peeling certain foods, so because it gets into the skin. So if you peel the fruit, then you're reducing down your pesticides. If you wash them, and sometimes washing them in a salt sort of solution can help to reduce the pesticide. So there's also a thing called the dirty dozen in the States in terms of what types of fruits have a higher amount of pesticides level. But the only thing I might say is the benefit in terms of organic, it's not proven that you need to eat organic to reduce your pesticide. Now, there is research to show that people who have organic diets have less pesticides in their urine, so it shows the load is less. But the evidence is stronger for the benefit of eating your fruit and vegetables for Parkinson's than not eating them because of the risk of pesticide. So I think we have to have a kind of, again, a practical approach to this. A lot of people can't afford organic foods. So I would just say, wash and peel your vegetables to try and reduce the exposure as you can, as much as you can.
All right, we're a little over time, so I'm going to ask both John and Rochelle last question, and then I'm going to do our closing remarks. Rochelle and John, I'll first go to you, Rochelle. It's the holiday season, and there's a lot of food temptation out there in terms of sugar, dairy, everything combined. What are your top 2 tips, 3 tips max for staying nutritionally sound during the holidays?
Well, I think, go back to John's point, the holidays are what they say are holidays. And I think people, should still enjoy them and allow themselves to have, bit of what they fancy, over Christmas. What I would say is just be mindful in terms of the quantity, in particular, of protein foods. So if you're having a big turkey dinner, and people end up often having, say, 1,500 calories in that meal, you will definitely be switched off. Your symptoms will be worse. So just be mindful about that in terms of I'm not so worried about the sugar over kind of a short period of time. It's more of a long game with the sugar. It's about the proteins switching you off in terms of your medications. So be mindful of not overdoing it in terms of protein portions.
Awesome. And John, what's your 1 tip for eating healthy during the holidays?
Remember that what goes in has to be used or it goes out. Make sure that you're exercising as much as you can, because the more you eat, the more resources you're putting in. You've got to burn that calorie that you've eaten. Exercise as much as you eat. What goes
Awesome.
in have to balance. Like I
Thank
say,
you. Thank
stay
you
in
so much.
balance.
Thank you so much, Rochelle and John. I appreciate all the information you've provided. Thank you everyone for joining us for our session. We hope you found the information valuable. If you did see the resources tab, make sure you download the resources in the resource tab. All of our talks have been recorded and will be available for viewing next week. We hope you will share this information with friends or support groups who might like to view these talks on their own time. Thank you again to Mitsubishi Tanabe Pharma America for supporting this program. And before we sign off, we want to invite you to save the date for the 7th World Parkinson Congress that will run from May 24th to May 27th in 2026 in Phoenix, Arizona, USA. It happens once every 3 years, and the next one promises to be quite amazing. We hope to see you all there. Thank you.
Hello, and welcome to the WPC virtual webinar series. My name is Eli Pollard. I'm the Executive Director at the World Parkinson Coalition. And this program has been a long time coming, starting back in 2019 at the 5th World Parkinson Congress in Kyoto, Japan. There were a lot of conversations about resources and services for people with young onset Parkinson's disease. And that conversation seeded this idea for a course. We actually took that information in 2019 and offered a live in-person pre-Congress course at the 6th World Parkinson Congress in Barcelona, Spain in 2023. There were a lot of people who could not join us in person in Barcelona, and they let us know that they really wanted access to these courses. And so because of their requests and because of interest within the community, we are now offering this course live virtually for everyone to access. So it's important to note that this entire program is being offered 9 talks in all. They were all designed by people with Parkinson's, particularly people with young onset Parkinson's, designed for other people with YOPD or people who want to learn about YOPD issues. You're going to hear this week about a wide range of topics, from parenting in Parkinson's to exercise in Parkinson's to when and how to make a disclosure about your diagnosis. The topics are wide and varied, and our faculty are true leaders in the Parkinson's world. With 20 faculty members, 12 of them are people who actually live with young onset Parkinson's disease themselves. Other faculty are care partners, movement disorder doctors, we have a nurse, we have a physical therapist, and others. It's really an incredible lineup, and you're in for a great treat. And if you miss a session, don't worry, we're recording them all, and they will be available for viewing as archive talks in the coming week. I want to thank Mitsubishi Tanabe Pharma America for supporting the WPC and bringing this program to you. We would not be here today without their support. So thank you, Mitsubishi Tanabe Pharma America. And lastly, I want to thank our faculty for sharing their knowledge, their experience, their expertise, and to all of you for joining us today and for supporting the WPC and our work throughout the year. Thank you, and enjoy the session.
Hi, everyone. Welcome to the World Parkinson Coalition's virtual YOPD program. My name is Becca Miller. I'll be your moderator for the next hour, and I'm thrilled to be joined by our presenter, Dr. Daniel Weintraub. Dr. Weintraub is professor of psychiatry at the University of Pennsylvania School of Medicine and psychiatrist at the Parkinson's Disease Center at the Philadelphia Veterans Affairs Medical Center. He's a board-certified geriatric psychiatrist, and he also conducts clinical research in the psychiatric and cognitive complications of Parkinson's disease and related disorders. Our session today is going to be him talking about the psychiatric and cognitive medication side effects in Parkinson's disease. We're so pleased that you've joined us here today. If you're not already aware, there are 9 talks in this virtual YOPD series, each falling under one of 3 categories. The individual track, talking about living with Parkinson's. The in relation track, focusing on the importance of relationships since the impact of PD is so broad. And then the medical track, where we're focusing on the medical management of Parkinson's with a focus on YOPD. So this talk falls under that track. And not to worry if you miss a session this week, because we're recording them and they'll be available by Monday next week for viewing. During this session, you'll notice a box on the right side of the screen with 3 tabs: a question tab where you can submit questions at any tab, and a resource tab where you can download various resources that are mentioned in the session. There aren't any specific resources for this session, but you can find the resources from all the other sessions under that tab. So lastly, I want to thank our generous sponsor, Mitsubishi Tanabe Pharma America. We wouldn't be here today without their generous support. So now we're going to go ahead and get started. So Dr. Weintraub, take us away.
Thank you, Becca. So I'll wait for the slides to come up and so should be one slide before that. And should I proceed now or wait for them to come? Okay. So hello, everyone. I'm Daniel Weintraub. I'm a psychiatrist at the University of Pennsylvania and also at the Philadelphia Department of Veterans Affairs. I'm a clinician researcher. I focus on the psychiatric and cognitive aspects of Parkinson's disease. And I want to thank the WPC for this invitation to present today. That I've gone to many WPC meetings now over the years, and it's really been a highlight for me in the sense for a couple of reasons. One is I think the WPC has always emphasized the non-motor aspects of Parkinson's disease, which is near and dear to my heart because that's what I focus on. So psychiatric and cognitive and other complications. And I think it's really a wonderful venue for people like me that see patients, but also are asking questions and trying to learn about the illness and understand it to lead to better management strategies to interact with patients and their family members and loved ones to understand the experience. So to me, it's always been a wonderful meeting. The slides that are here, you can see the logo from the WPC meeting in Barcelona in 2023. That was because the first time I presented this specific talk was there. I did update the slide some for today, but I just left the pretty pictures of Barcelona on the first slide. But of course, the next meeting's in 2026 in Phoenix, Arizona. Okay, so I think we can advance the slide now. These are disclosure slides. I will say that I'm only seeing this in the upper right-hand corner, so I'm doing my best. I don't know if I should be seeing it in a different format. That's a question for the people. If I should, let me know. If not, I'll just operate off of this kind of third of the screen that I can see, upper third, upper right. But anyway, these are my disclosures. I don't need to go through them in any more detail. They're available. And next slide, please. So this is an introduction slide. Next. So there's this whole notion when thinking about neuropsychiatric symptoms in Parkinson's disease or psychiatric and cognitive symptoms broadly, that's what I'm calling neuropsychiatric symptoms, about what's the impact of the disease versus the impact of the Parkinson's treatments. And today, my assignment is to focus really on the impact of Parkinson's treatments, which is certainly relevant to people with young onset Parkinson's disease. But first, we have to recognize that the neural substrate, as we call it, or the biological changes that occur in Parkinson's disease are very relevant to psychiatry and psychiatric symptoms in general. That includes the brain regions that are affected, the neurotransmitters or chemicals, the pathways. They're all implicated not only in Parkinson's disease, but in psychiatric disorders as well. We know that patients can develop psychiatric symptoms before their diagnosis of Parkinson's disease, which really, again, highlights the biological contribution because these are people that don't even know they're going to develop Parkinson's disease at this point. And I list a couple of those disorders here. Then we get to the Parkinson's treatments themselves. So once somebody receives a diagnosis of Parkinson's disease, at some point they start treatment, often more than one treatment over time. And these are treatments that primarily, if they're medications, target some of the chemicals that I mentioned before, dopamine, norepinephrine, acetylcholine. And we also know that there's this kind of cross-fertilization between neurology and psychiatry where Parkinson's treatments are used for psychiatric disorders. And that includes things such as selegiline patch. Selegiline is what's called an MAOB inhibitor, and that's approved in psychiatry for treatment-resistant depression. And deep brain stimulation, which was used originally for Parkinson's disease, is used rather broadly within the psychiatric community as well for disorders such as obsessive compulsive disorder. Next. So if we dive a little bit into some of the specific disorders that can arise or are more common in Parkinson's, depression, anxiety, and apathy are what we more broadly call affective disorders. Next. So we know that depression occurs in the prodromal or at-risk state for some people with Parkinson's disease. So if you look back from the time of diagnosis in the period up to maybe 5 years before, there's an increased risk of depression in people who are ultimately going to develop Parkinson's disease. So that does speak to the biology of these symptoms, that it's hitting a part of the brain before it hits the part of the brain responsible for the motor symptoms that's responsible for emotional control, or in this case, mood. Next. Now, fast forwarding to the Parkinson's treatments, which is really my focus for today, we do have evidence that once somebody has an established diagnosis of Parkinson's disease and has a diagnosis of depression, that at least one class of Parkinson's medications, in this case dopamine agonist, has antidepressant properties within Parkinson's disease. And this is a large randomized controlled trial, kind of the most rigorous scientific clinical trial we have, that showed that patients randomized to pramipexole in this case versus placebo had a greater improvement in their mood, even accounting for their improvement in motor symptoms. And of course, there's 3 dopamine agonists, pramipexole being one, ropinirole another, and rotigotine patch the third in the United States. Next. We also know that MAOB agonists, so the most commonly used MAOB agonists are rasagiline and in the past selegiline, also increase the levels of dopamine in the brain. This was data from a study called the Adagio study that showed that patients who were randomized to rasagiline versus placebo had some improvement in their mood. These are newly diagnosed, untreated patients at the time of the study. Next. However, there was then a more formal trial to test rasagiline for people with established Parkinson's disease and actual diagnosis of depression that was not positive. So the jury is still out, I would say, about the impact of MAOB inhibitors on mood. Next. About 10 to 15% of Parkinson's patients over time will receive deep brain stimulation as a procedure, and there's 2 main stimulation areas of the brain, the STN or subthalamic nucleus versus the GPI or globus pallidus interna. I think the animation on the slide isn't working out exactly, but what I'll tell you is the content of the slide is there's been some evidence from studies that perhaps the GPI has a preferential effect or a better effect on mood after DBS versus the STN, but there's other research that suggests that there really is no difference between these 2 locations. But there are some neurosurgeons, when they're considering which placement to choose for the stimulation for the electrodes, will consider a person's psychiatric state prior to the surgery. Next. For a long time, there was some concern that deep brain stimulation might be associated with suicide. This was mainly from suicide ideation or suicide attempts or even suicide completion. This was from an early series that looked at a number of patients who were really followed for quite a long time after surgery, like almost a decade, and found that there were several people who had committed suicide and that they felt that that showed an increased risk with deep brain stimulation. But I thought that literature was somewhat limited. And since then, I don't really think that research has borne that out to be true. And next slide is one study where we attempted to look at this. Was this in the Department of Veterans Affairs called the CSP 468 study, where patients were randomized to deep brain stimulation or what's called best medical therapy. And over the first 6 months after the surgery or maintaining best medical therapy, there was really no difference in suicide ideation between the 2 groups, and there were no suicide attempts. So I think when you do more formal controlled research, the results don't suggest that GBS is associated with an increased risk of suicide. Next. Another issue that comes up, I'm sorry, all of the animations are not working here, but I could talk you through this. That there's something called serotonin syndrome. So for anybody who's on an antidepressant, and the most commonly prescribed antidepressants are SSRIs, selective serotonin reuptake inhibitors, and or co-prescribed an MAOB inhibitor. I've already mentioned that those are rasagiline and selegiline. You'll bring up a red flag from the pharmacy about the possible interaction of what's called serotonin syndrome. And if this occurs, it's quite a serious syndrome where people have mental status changes, neurological symptoms, and it really requires prompt emergency treatment. And that's whether you're on an antidepressant and are adding an MAOB inhibitor, or you're already on an MAOB inhibitor and you want to add an antidepressant. What you can't see on this slide is that we looked at this study that I mentioned before, the Adagio study, and there were about 100 people that were on rasagiline and an antidepressant for the first 6 months of that study, and none of them had evidence for what we call serotonin syndrome based on the adverse event reporting for this study. So if serotonin syndrome occurs, and I'm sure that it can, it seems to be quite rare with this particular interaction between an antidepressant and Parkinson's medication. Next. So apathy was one other affective disorder. So apathy is a loss of motivation, and it can be manifest in various ways. But this was evidence from a study of people undergoing deep brain stimulation who had their dopamine agonist discontinued after treatment, after surgery, that a number of them became quite apathetic when they had their dopamine agonist withdrawn. And then they did a clinical trial where they were either randomized back to their dopamine agonist or to placebo. And it showed that those that were put back on their dopamine agonist had an improvement on their apathy. So it does suggest, at least in a subset of patients, that dopamine agonists can have anti-apathy effects. But this may only be to the subset of patients that I was describing that had undergone deep brain stimulation, because there was another study more formally targeting apathy in Parkinson's disease that was negative using a different dopamine agonist. Next. So in terms of clinical management of these disorders, there's some evidence that dopamine agonists have antidepressant effects and anti-apathy effects. There's evidence that antidepressants that target other neurotransmitter systems affected in Parkinson's disease work. I'm not presenting that because they're not Parkinson's medications, but we have multiple positive studies for SSRIs or serotonin antidepressants, and also for an older antidepressant class called tricyclic antidepressants that targets a different brain chemical, norepinephrine. Next. Psychosis is another syndrome or disorder that can occur in Parkinson's disease. These are primarily hallucinations and delusions. Next. So there is some evidence now that minor psychosis symptoms can occur even in people that are untreated, newly diagnosed with Parkinson's disease. So those are people that may experience something in the periphery of their vision, either a person or something moving, or may misidentify an actual object that's in their visual field. This study did demonstrate that some people who are untreated with Parkinson's disease can experience that. Next. But what we found, again, apologize for the graphics here, is that from a study called the PPMI study, or the Parkinson's Progression Markers Initiative study, where people are untreated at diagnosis or at study entry, is that the rates of psychosis are quite low in Parkinson's disease patients, and similar to the rates that you see with the healthy control group in the study. But what happens over the first few years of the study is that the rates of psychosis go up in Parkinson's disease, and they stay level or steady in the healthy control group. And the main difference is that dopaminergic therapy or Parkinson's medications are being introduced over the first few years of the study, and it's those patients who have Parkinson's medications introduced that are most likely to develop new onset psychosis. Next. The relatively likelihood of Parkinson's medications to induce psychosis, really any of them can, I think, in vulnerable people. Vulnerable be those that are older or those that have cognitive impairment, so memory impairment, for instance, are more prone to develop psychosis as a side effect. But dopamine agonist and what are called anticholinergics seem to have the greatest effect. And anticholinergics are not commonly used anymore, but those include things such as benztropine or trihexyphenidyl, and they are still occasionally used by people with Parkinson's disease. Next. So in terms of managing psychosis, there's expert recommendations about which medications should be discontinued first. This is Parkinson's medications if somebody is experiencing psychosis. And at the end of the day, what typically happens are that the top 4 rows are discontinued, and then patients are managed just with levodopa if the psychosis symptoms have not improved. Next. We have one FDA-approved antipsychotic for psychosis, and it's called pimavanserin. It's been around for close to a decade now. And the point I bring this up is it's not one of the Parkinson's medications, it's a psychiatric medication, but I've spent time talking about the dopaminergic effects and its impact on psychosis, yet pimavanserin does not affect dopamine in any way. It affects only the neurotransmitter of serotonin. So it has kind of a unique mechanism of action where it still has antipsychotic effects, but it's actually not targeting dopamine. Next. So in terms of clinical management of psychosis, nearly all PD medications can potentially cause psychosis, particularly in older patients with cognitive impairment, and that antipsychotics that target the serotonin system versus the dopamine system are the preferred medications to use in PD. And that's not only pimavanserin, but other ones that have more of an effect on serotonin versus dopamine, what are called atypical antipsychotics, because those are thought to affect the motor symptoms of Parkinson's disease less. Next. Moving on to cognitive impairment now, which is a significant concern for many Parkinson's patients. Next. So in terms of Parkinson's medications and their effect, there really is no known differential effect in terms of which medication you start when you're newly diagnosed and if you're followed long term. So this was a study that looked at 2 types of ways of looking at medication. One was whether you started levodopa versus non-levodopa. And then the second was, if you didn't start levodopa, did it make a difference if you started a dopamine agonist or an MAOB inhibitor? And in terms of cognitive outcomes, none of these medications had a better or worse effect compared with the others. So whether you start levodopa, a dopamine agonist, or an MAOB inhibitor, years down the road, the likelihood of cognitive impairment was the same. Okay, next. There has been interest in whether MAOB inhibitors, just as I mentioned, one had been tested for depression and Parkinson's disease, also whether boosting dopamine levels might improve cognition. So this was a study that looked for the treatment of mild cognitive impairment. So that's some degree of cognitive changes, but not severe enough to meet criteria for what we call dementia. So mild cognitive impairment, and the introduction of an MAOB inhibitor did not improve cognition in this study compared with inactive or placebo treatment. Next. Colleague at University of Pennsylvania, Dr. Allison Willis, is an epidemiologist and has spent a lot of time looking at different medication use in large data sets such as Medicare and Department of Veterans Affairs databases, and has found that the use of potentially inappropriate medications, and an extensive list is listed here, may be present in Parkinson's disease. And I highlight this because these are not core Parkinson's medications, but other medications, psychiatric and used for medical conditions, that may be on a medication that could be potentially harmful from a cognitive standpoint. So I think this is worth noting for people and kind of having lists like this handy and being able to discuss with your physician to make sure you're not doing anything to harm your cognition by being on a medication like such as these. Next. In terms of deep brain stimulation, there's been some sense for a long time now that people that undergo deep brain stimulation, a subset of them, maybe 15%, have kind of an appreciable decline in their cognition in the 6 to 12 months after the surgery. More recent studies that have looked at people getting DBS in an earlier stage of the disease or younger Parkinson's patients seem to conclude that it's actually pretty well tolerated in that group. So the earlier studies tend to have more advanced people, long-standing Parkinson's disease, older patients, and those are more cognitively vulnerable anyway. So it seems like the DBS, at least in younger patients, seems to be well tolerated. Next. So clinical management in terms of cognition, I would say there's no evidence that which Parkinson's medication is started or added over time has differing long-term impact on cognitive outcomes in Parkinson's. Anticholinergic medications may be particularly problematic. Those are both the anticholinergic medications that are used to treat Parkinson's, but other over-the-counter medications that are used, for instance, as sleep aids or antihistamines that also often have, or urinary control medications that have anticholinergic properties. Polypharmacy and higher doses are likely to be associated with confusion. So the more of these medications you're on, or the higher the doses, just compounds the problem. And DBS is more likely to be associated with cognitive changes in patients who are older with more advanced disease or who had pre-existing cognitive impairment before the surgery. So that's why most surgical teams will do detailed cognitive testing prior to operating on someone. Next. Impulse control disorders. Next. So these are disorders primarily that revolve around 4 main behaviors, although it can manifest any number of ways. So these are compulsive or increases in gambling, buying, sex, or eating behaviors, but it really can be any behavior that's done to an extreme. And this is a slide that shows data from, again, this Parkinson's Progression Markers Initiative study, or the PPMI study funded by the Michael J. Fox Foundation, showing that if you look at untreated patients with Parkinson's disease before they ever start medications, their rates of these ICDs or impulse control disorders are no different than healthy controls. That it only happens once the medications are introduced. And if we go to the next slide, this was data from a large study in over 3,000 Parkinson's patients in the United States and Canada that showed that the greatest risk for having an impulse control disorder was dopamine agonist treatment. So I've already mentioned that class of medication before, but we found out that even levodopa has an effect. It's not as strong an effect as dopamine agonists, but it seems to have an effect, particularly at higher dosages, in contributing to these behaviors. And next. And other studies have shown that other Parkinson's medications also slightly increase the risk. So amantadine, which is used primarily to treat dyskinesias, and I've already mentioned rasagiline several times now, that's an NAOB inhibitor. So really my conclusion is that any of the Parkinson's medications can potentially contribute to this development of an impulse control disorder, although the risk is clearly the highest for dopamine agonists. Next. There was some question, and it's unanswered still, about whether long-acting dopamine agonists are different. And this is an incredibly busy slide because it's meant to have animations where you wouldn't see it all at once. But this was a study of a large number, close to 1,000 Parkinson's patients from Europe, primarily, who were treated with rotigotine patch in an open label fashion. And the rates there over time, over many years, seem to be lower than what I was reporting from previous research. It did seem that at higher doses, the risk went up. So there does seem to be a dose effect, which has also been shown for other studies of dopamine agonists. And then finally, what the red columns in the bottom are meant to illustrate was that the time of onset, the average time of onset for developing one of these problems for those that did after the introduction of the rotigotine patch was about 4 to 5 years. So these problems may not arise immediately, and if you're being followed clinically, it's something you need to be mindful of for as long as you're on a dopamine agonist. Next. This slide, again, a complex slide with layering, is really demonstrating that one of the core strategies we use for people that are appropriate from a motor standpoint and have an impulse control disorder is the introduction of deep brain stimulation. And the reason for that is that if deep brain stimulation is successful, one of the outcomes is that you're on less Parkinson's medications afterward. And if you're on less Parkinson's medication, particularly less dopamine agonist therapy, then the likelihood is that if you have an impulse control disorder, those symptoms will improve afterwards. And that's what this slide demonstrates. Next. There has been more recent literature about some people developing impulse control disorders after deep brain stimulation. So they didn't have it before and they only have it afterwards. And I've been doing this for a long time now and I've seen many patients. And I remember one patient who I thought really developed this as a new problem after surgery. And my only conclusion, and this is kind of a guess, I guess, is that it has to do with the post-operative dosing, that for patients who may not be able to decrease the dose of the medications and remain on the same amount, plus then have deep brain stimulation on top of that, that seems to fit the picture of somebody who may develop a new onset impulse control disorder after surgery. Next. So clinical management for this is that all Parkinson's medications have been associated with impulse control disorders. The strong effect is for dopamine agonists. It's not clear at this point if long acting. So long acting can be, so it's once a day, which can be either oral or patch, but it's less likely if it's not clear if those are less likely to cause impulse control disorders. Deep brain stimulation overall leads to a decrease in ICD symptoms, but new onset cases have been reported. It may have to do with the postoperative dosing, and there's also different areas of the brain that can be stimulated, different regions with a DBS, and some are more linked with emotional regulation, so that may play a role as well. Changing Parkinson's medication usually helps, but there is a syndrome that's been described called dopamine agonist withdrawal syndrome, or DAWS, where patients who are on a dopamine agonist and have an impulse control disorder can go through withdrawal symptoms when they're coming off it, which can be quite uncomfortable for them. Next. And finally, the category, this is the last disorder to discuss, called non-motor fluctuations, or yes, and I'll describe what that is on the next slide. So those are non-motor symptoms, not motor, but non-motor symptoms that occur as patients are in the off state as their Parkinson's medications wear off. Typically, it's the levodopa we're talking about. So some of you may have heard of these off periods. And these off periods can not only have motor symptoms, but they can have non-motor symptoms. And in this original study that really described this syndrome, they asked 50 patients, Parkinson's patients, who had motor fluctuations about other symptoms, non-motor symptoms, and all of them declared that they had had some non-motor fluctuations in addition to motor fluctuations. So as their medication was wearing off, and if we go to the next slide, it describes in detail what symptoms were most commonly reported. So anxiety is a common non-motor fluctuation, slowness of thinking, fatigue, irritability, even hallucinations. Although those are less common in the off periods, they're more likely to be in the on periods from the heightened dopaminergic effects. Next. So in clinical management, the Parkinson's doctors, the ones that are actually managing the motor symptoms, have a range of options available to supplement the levodopa that people are typically taking to kind of smooth out the dopamine levels and to minimize fluctuations. Sometimes patients, again, will undergo deep brain stimulation because they'll be on less medication that way afterwards. We do sometimes use psychiatric medications, for instance, antidepressants and anti-anxiety agents, but we don't really have good evidence that they help with these non-motor fluctuations specifically. Next. So here's the, I think this is my last slide, the key takeaways from the impact of Parkinson's treatments on neuropsychiatric symptoms. There's possible adverse effects from some of the Parkinson's medications, and those would be primarily impulse control disorder, psychosis, and over time, the development of non-motor fluctuations with chronic levodopa treatment. There's possible benefits, so they may have mood-enhancing effects, anti-apathy effects, or even impulse control type symptoms that are not harmful, but actually some people find beneficial, such as increases in creativity. And this would primarily be for dopamine agonists. So different medication classes have different effects. The impact of deep brain stimulation appears to be variable, but overall, in terms of psychiatric symptoms, I'd say it's beneficial, and for cognition, maybe a slight decrease on average. And that there's certain patient level characteristics that predict adverse events, such as younger age being more likely to develop an impulse control disorder, or older age or cognitive impairment being more likely to develop psychosis as a side effect or cognitive impairment. So I think that's the last slide. If we just advance once more, just to make sure there's nothing else. Yeah, so I think we got through everything.
Great. Thank you so much, Dr. Weintraub. This is such a detailed and comprehensive look at all the different, medications and treatments and their potential benefits and kind of negative impacts that can happen. We had a couple questions from the audience, and please feel free to pop in with your questions, and I'll try and present them as time permits. But I wondered if you knew, you had said that the rate for DBS among all Parkinson's patients was about 10 to 15%. Do you know if that's different for young onset for YOPD folks? Is there a higher rate of folks having DBS on with those diagnosed earlier, or is that not known?
Well, I think if you follow a young onset Parkinson's patient for long enough, they become an older Parkinson's patient, and there
Sure.
they would be falling under that same category of 10 to 15% overall. It's just they're probably not going to be having it at age 45 or age 50. That would be more unusual, I think. So I think
I don't like having to fall under that category, but I do because I'm 50 and just had it 3 years ago.
yeah, so it does occur. I think it's typically people, and traditionally, I should say, not typically, traditionally, it's been people who have been older and have long-standing disease. Now, you can be 50 and have long-standing disease, so that would make you more likely to have it. And I think the good news is that if that is recommended and it makes sense because of side effects of medications or not working well, I think a young person who's cognitively intact is likely to tolerate the surgery very well.
Mhm. Great. Hopefully I qualify as cognitively intact. Well,
I think so. I think so.
So I wanted to ask you two questions. One is about what the Produodopa pump, the new pump that came out that's sort of similar, I think, to like an insulin pump, in that I don't know if you're familiar with that, but is that, I know that's sort of newer in the space. Is that how can we think about that in terms of kind of interactions with the other medications that you might be taking, et cetera?
Yeah.
Can you
So I mean,
describe it a little bit, actually?
sure. So there's actually the original Duopa. So that was through the gastrointestinal system and involves, more elaborate procedure and working with a gastrointestinal doctor. And now there's the more recently approved subcutaneous levodopa, carbidopa, that's kind of a modification of that. But what's in common for them is that they're really aiming to do kind of more of a 24-hour delivery, constant delivery of levodopa, as opposed to kind of the pulsatile oral administration where you're taking it every several hours or so. So I think the hope is that by smoothing out the levodopa dose, you'll have less fluctuations, and potentially those less fluctuations, but not only be less motor fluctuations, but less non-motor fluctuations. And so I think the preliminary research does suggest that it's helpful for non-motor symptoms as well. In terms of its impact on like major depression or impulse control disorders or psychosis, I think it's not known if it has benefit in that regard yet. We need more time to really evaluate that, like more chronic exposure. Often these short-term trials aren't really able to address all of these issues. And they really focus primarily on the motor symptoms when they're looking to have these medications approved.
Right. Yeah, I mean, and this is a heavier topic, but I wanted to talk a little bit more about the incidence of suicide and death by suicide, and whether that is more common among younger onset folks, or is there not a difference between those two?
Yeah. Well, but just kind of stepping back, when I first came in, I think it was to this field, which is over 20 years ago now, it was assumed that Parkinson's might have a higher risk of suicide. But then
Mhm.
the early literature didn't really suggest that at all. And people hypothesized that maybe because there's changes in motivation or there's certain motor limitations or any number of kind of hypotheses about why that might be true. And I must say, again, drawing from my own clinical experience of having seen many people over many years now, that my knowledge of patients committing suicide or attempting suicide is it's quite low. There have been some more recent studies that look at like 1 million people in a database and compare those with Parkinson's versus those without and show a slightly increased risk. But those are studies it's hard to draw many conclusions from. And even in those studies, the incidence or the likelihood is quite low. It's very rare.
Yeah.
Now,
I mean, I
to
think
then go,
important to mention that if you are ever feeling that way, there's so many different places to reach out to, how, hotlines, et cetera. But that there's also, I think, the strength of the Parkinson's community, which comes through in the WPC, which I'm a big fan of personally. But that for me, there's always someone to reach out to across the world who's awake when I'm awake, because we all know Parkinson's can cause sleep problems.
yeah, yes, yeah, and you're tackling a whole different side of it. I was just presenting the data. You're presenting kind of the human element and the management, which is obviously very important. I mean, there's a national suicide hotline in the United States, and I do think there's a lot of resources. Your one other point was about, or question was about young onset. I don't think it's known if people who have young onset are more likely to experience suicide ideation than older people. When we did examine this issue, this is the last point I'll make. We found that people might have death ideation, like kind of a sense of hopelessness or helplessness, or feeling like life might not be worth living. Those kinds of thoughts were more common than an actual thought about, taking one's own life or harming oneself.
Huh. I found for myself, just on a personal note, that can happen when I'm feeling more off, like you were talking about the non-motor fluctuations, that when I'm feeling more off, and sort of that leads me to feel more hopeless and helpless if I can't really do what I want to be doing, even if I have lots of plans. But that the sort of inability to do so is very frustrating and can leave me feeling more down.
Quite impressed by had the impact of non-motor fluctuations. You're describing one end of it. The ones that are most memorable to me are actually the people that develop these kind of crippling, disabling anxiety attacks as their medication's wearing off. So these non-motor fluctuations can be quite powerful.
I think it's so important to know about them too, because for me, at least, one thing that helps me is knowing that they'll pass, right? Once my medication kicks back in, I know that the feelings will subside. Whereas, if it's just sort of free floating and I have no idea why it's happening, it can be a totally different experience.
I agree. That's a good point.
I was going to ask you if you could say a little bit more about the DAWs and what the dopamine agonist withdrawal
Yeah.
syndrome and what that looks like.
It's interesting because that was described, once we figured out that the most effective way to treat impulse control disorders was to get people off the dopamine agonist, because it really does typically make the problem go away. But if you do it kind of abruptly from a higher dose, particularly, to off the medication pretty quickly, people can experience this syndrome, and it really has multiple components. It has kind of a psychological or cognitive component where people just feel bad, they feel upset inside, worried, and it has a physiological component where they actually feel like they're withdrawing. They get stomach upsets, sweatiness. So it's almost like any substance where your body and brain gets used to being on it, and then you abruptly or quickly take it away. You go through both a behavioral and a physiological withdrawal syndrome, and it can be quite uncomfortable. And it's typically relieved if somebody goes back on the medication. But the problem is, being back on the medication means they may also have the impulse control disorder. So
I was trying to balance these two pieces. Is there a kind of a way to taper this?
you can do a tapering. People try all kinds of things. They try to taper, they try to maybe not discontinue it, but just go to a lower dose. Some people have even tried going to a different dopamine agonist. As I said, there's 3 of them. So maybe you didn't tolerate one, but you could tolerate another one. Some people go up on the levodopa dosage to compensate. So you're getting more, not getting less dopaminergic therapy overall. You're just getting less of the dopamine agonist, but more of the levodopa. All of these strategies are tried, but there's really very little evidence to suggest whether they work or not.
Okay, so more research needs to be done, clearly.
For sure.
Um, and then in terms of the impulse control disorders, you said, yeah, I think you mentioned something about them being more likely in younger folks. Can you say a little bit more about
Yeah,
that?
there has been some research that younger people, particularly younger men, may be more predisposed to that. That's been reported in several studies. Um, there's other predisposing factors. So if you have a personal history of one of these, like prior to Parkinson's, it makes you more vulnerable. If you have a family history, it makes you more vulnerable. If you have a substance abuse disorder history, that seems to have an impact. And then some of them have differential sex effects or gender effects, but and that they mirror what's true in the general population for these disorders. So gambling doesn't seem to really differ between men and women, but sexual behaviors are more common in men, and eating and buying behaviors are more common in women. But that reflects what's also true in non-Parkinson's patients with these problems.
Interesting. Great. And then there was one other question I had. Are there any kind of upcoming medications or other things that you're really excited about in this space?
Well, I would say maybe. There's lots going on. I would say, because I kind of have a view of the field. And I'd say most of the research in the areas that I was presenting are really focused on cognitive impairment, I would say. So the treatment of mild cognitive impairment or dementia using a variety of mechanisms, some quite novel. So I think that's really good. I'd say the other disorders, there's not so much going on in Parkinson's. There are some. I will say, like psychiatry in my lifetime, again, 20 plus years as a psychiatrist, is going through an explosion right now in new treatments. I'm not talking about psychiatry and Parkinson's, but psychiatry in general. For many, many years, we were using the same antidepressants or the same antipsychotics or variants of them, and that was all that was new. Now, in the past 5 years or so, there's all of these new mechanisms that are being explored in medication wise. There's many kind of stimulation techniques that are being used, transcranial magnetic stimulation, transcranial direct current stimulation, and so on. So there's just like an explosion. And I think some of those eventually may have applicability to Parkinson's. So for instance, ketamine is approved for the treatment of severe depression, and S-ketamine, which is its nasal spray variant, is also approved for depression. There's now a few ketamine studies ongoing for depression and Parkinson's disease. So we'll learn in the coming years if those are effective treatments. But again, I'd say most of the treatments focus on cognition. And the final point I'll make is, as people know, the field is trying to not only develop symptomatic therapies, but disease targeting or disease modifying therapies. And the hope is, if you're targeting, for instance, something like synuclein aggregation or Lewy bodies, as we call them, that if you're able to impact on that in some way, not only will that help the motor symptoms, but it should also help with the non-motor symptoms I'm talking about, because they're part of the same disease process. It's not like it's a separate disease.
Great. How do you suggest that people find someone to work with, psychiatric experts who know about Parkinson's and can work with YOPD folks?
Good luck, I guess I would say.
It's
And
not easy even to find a therapist or a psychiatrist, huh?
probably easier to find a therapist. So by therapist, I would be referring to like a psychotherapist, which are typically social workers, psychologists, other types of professionals with psychotherapy training. That's probably a little bit more easy, although I wouldn't say easy to find one with expertise in Parkinson's unless you're at a major, academic center. That's not likely to be common. Finding a psychiatrist that has any experience with Parkinson's is just very hard to do. So really, you would, because there's just not many people that do this. There's just not many geriatric psychiatrists in general, much less geriatric psychiatrists that work with Parkinson's, because most Parkinson's patients are older, they're not younger, most of them. So I think you'd be looking for maybe somebody who would bill themselves as a geriatric psychiatrist, who would have experience with neurological disorders, or a neuropsychiatrist, as they're called, or just a good, competent adult psychiatrist.
Yeah. I found in my experience, if I find someone that I like, a psychiatrist or a therapist, I can help educate them to some extent or
Yeah, I
interest them
think
in
that's a
getting
good point.
involved.
It's
Because
such
it
a
is,
yeah.
sorry, go ahead.
No, you go, Beck. I didn't mean to interrupt you.
No, I was just saying that because it is hard to find someone who's specifically trained or has experience working in this area, but if you find someone you like, at least you know you like them.
Yeah.
Which would be so important, just to have that relationship with someone.
I think your point is a good one, and I just want to echo, how complicated the illness is, and it took me forever, it felt like, to learn the basics, and I'm still being surprised, every day. We say it all the time, but it really is true that every patient is different, and you just are constantly learning something new, and the treatments evolve, and new treatments come out, and there's good parts to the new treatments, there's complications to the new treatments, and it's just endlessly complicated, I would say, Parkinson's.
Yeah, I mean, I think for that reason in particular, it's good to find someone you can really partner with and then go on this journey together.
Yeah, I agree. Yeah.
Um, well, I think that's about it in terms of the questions, unless there's any others. Thank you so much for your time and expertise in this, Dr. Weintraub. It's really been great having this conversation with you. Just a few things as we wrap up, just to let everyone know that all these talks have been recorded and will be available for viewing next week. And we hope that you'll share this information with friends or support groups who might like to view these talks on their own time. I want to thank again to Mitsubishi Tanabe Pharma America for supporting this program. We really, really appreciate their support. And to just make another pitch before we sign off, to invite you to save the date for the 7th World Parkinson's Congress that will run from May 24th to 27th in 2026. And this time we're going to be located in Phoenix, Arizona, sunny Phoenix. So it only happens every 3 years, so don't miss it. Put it on your calendar. There's so many great people there to meet, people you might already know from social media, other places. Dr. Weintraub will be there. I will be there. And we hope to see you there. So thank you so much.